Morning.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone. A pleasure to be here again and see you all. My name is Dr. Vanessa Rapier, and I'm your host for this morning and this morning's Health Hour. And just as a reminder of all of you that are on here, this is CATHIP's Health Hour, and CATHIP is a collaborative and educative program that really is focused on empowering health literacy. And it's a real way of supporting us within Black communities from African heritage, Caribbean heritage, so that we can really advance and support our health, but not only of ourselves, but also of those in our communities and our networks as well. And it's always a pleasure to be here on a Saturday morning. And as I always say, that we don't take it lightly that a Saturday morning at 11 a.m. that you're here with us week on week to learn and engage our communities. CATHIP is as I've said, it's a collaborative and it's formed of a number of organizations. And I just want to highlight them here today. So we have the Caribbean and African Health Network. We have the Black Health Initiative. We have the Royal Assembly Redeemed Christian Church of God in Sheffield. We have RAFA International Development Agency. We have Croydon BME Forum and Enfield Caribbean Association. And it's the key thing about this collaboration is that we're not just focused in one area, it's nationally and bringing everyone together to learn. So again, great to see you all. And as always, I always say this, but we have fantastic people that come and give us their time to share their knowledge and experiences. And the real beauty of it is that it's people from our communities as well. And as we all know, representation is so important, so that we've got people that can relate to our community's needs. So we are honored today to have Dr. Valentine Ngwa, who is a consultant geriatrician, and he's going to be talking to us about caring for our older people. And every session I always really look forward to, even when I'm hosting and I just am listening. But this is a particular one because I feel that it affects us all, whether it's us personally in later years or it's us looking after those in our network. So really excited to hear Dr. Ngwa speak. We have the chat function within Zoom, which is for you, everyone out there, for you to put your questions through, anything that you don't understand, anything that you want to learn more. I'll be bringing those questions together at the end, so Dr. Ngwa can kindly go through that with us. Those of you that are tuning in on Facebook and YouTube, you're not exempt. Please get those questions through. Colleagues are in the back end bringing those questions to me as well. And also, if you'd like to verbally speak at the end, feel free. I'll encourage that for you to put your hand up and be part of the conversation as well. So without further ado, I'm going to hand over to Dr. Ngwa, and again, thanking you for your time and being here today.
Thank you very much, Dr. Pierre. It's a pleasure to be here. It's my honor to be here. And as you're right, this is something that concerns us all, so we're all in it. I'm Dr. Valentine Ngwa. I work as a consultant physician and geriatrician in the Mid-Yorkshire hospitals in Wakefield and Dewsbury. I'm also a social gerontologist with a research interest in aging, and I'm more particularly looking at aging in the Afro-Caribbean community. I'm going to share my screen if I may. Is that coming out okay?
Perfect. Thank you so much.
Right. So I'm going to try and talk about the vulnerabilities as we get old. But again, I'll end by hopefully giving a bit of a brighter picture, because vulnerability does signify quite a few negative connotations to aging, which I think personally that they shouldn't be. I always get asked this question. I keep asking people this question: when do we say somebody is old? And I think that's a question which people have different ideas, and society have different ideas as well. There are those who will say 60, there are those who will say 75. It depends on society where you're from as well. If you're in a society where people live only to about their 60s, then when you're 45, you can be considered to be old. But these are two ladies of the same age. At this time, they were both 80, while one seems like she's on the way to the nightclub, the other one is definitely not looking able to get up and walk. So the best answer I ever got from somebody was, old age is when you feel old. And I think that really makes a lot of sense. And that's something we're going to try and talk today. But I'll set the stage by differentiating between aging and old age and the various types of age that we do have. Now, when we say aging, it doesn't mean old age per se. We all are aging. I mean, from the day you're born, you're aging. Though there are colleagues of mine who will say, well, you're growing up until you're 30, then you start aging. But we could argue that to say that anything that happens to you at age, say 1 or 2, could have significant consequences for the rest of your life. So you can consider that as aging as well. Now, what we commonly deal with is chronological age, because we find it very easier to relate to. You're 1, the next year you're 2, you're 25, next year you're 26, that's easy. And those who say age is just a number makes a lot of sense as well. Because what's more important is not the number, but it is how physiologically or how biologically you are. So the biological age actually actually signifies aging better than chronological age. And also more important, because you can reverse it. You can go forward and it can come backward, unlike chronological age where it just goes forward. What does that mean? Somebody could be chronologically 40, but biologically 60. Or somebody could be chronologically 70 and biologically 50. It is that tendency that we're going to talk about today. And of course, mental age is something which we know about. In where I come from, in Cameroon, they always used to say a fool at 40 is a fool for life, which means that by 40, you're expected to have had the kind of mentality of responsibility. And so we expect people's mentality to also grow as they age. When COVID came, it uncovered a lot of things as well. And it highlighted the fact that the biological age was what was more important. Though we know that people who were above 65% had the largest burden of disease, those who had more mortality and those who suffered more were above 65. But there were people at 90, at 80 who had COVID and had no significant symptoms. There were people at 40s who actually passed away from the disease. So COVID age tried to mimic biological age by looking at the things that happen to us as we get old. They don't have to, but they do. And we'll talk about as we move on. Now, when it comes to medicine for old people, we have to not make it be subjective. We have to put a boundary to say, when do we now go to under medicine for older people? Again, this is a name in which has got a lot of debate around it. So pardon me if I use it. Different people say geriatrics tend to be a bit more negative when it's used. Elderly and complex care or medicine for old people. You hear a lot of ways there's people say depending on where you're talking, who you're talking to. But some centers will use more age-based. So they'll say, oh, if you're 80 and above, you go under medicine for the older people. Others use more of needs-based. Who are you? If you're needing cares at home, if you're in a care home, or you need carers at home, or you can't mobilize independently, or you're having what we call frailty syndromes, then you go under medicine for the elderly by and large. If you're 65 and above with any of the frailty syndromes, then you are most likely looking at being under medicine for the elderly. And what are these syndromes? The instability, mobility, confusion, incontinence. Now, these are very deep-seated reasons. Elderly people come to hospital with these things. They are very deep-seated why this happens. Instability and immobility are actually talking about the ability to fall easily. Now, these are things, for those of us who believe in evolution, these are things that we evolve to become. So we evolve to become bipedal ambulatory. That is a very unstable position. And that's a higher function. When that fails as false. We evolve to be able to have divided attention, but still maintain concentration. So people listening to me today, they can be thinking about something else as well, but they can still concentrate on what I'm saying. When that aspect fails, it fails as confusion. And when continence fails as incontinence, this is a higher order function, which means therefore that the things that happen to us as we get old, the bad things, are the failure of complex biological mechanisms, and a human being is a complex mechanism. So our higher order functions start to fail, and that's why you see them come to hospital with these things. Now, an older person will come to hospital for various reasons. Of course, all other medical and surgical problems, they have more of it actually, because of their, again, I'm trying not to use older people as a homogeneous group because it's not. It's a wide range of, so if we say from 80 and above, there are 90-year-olds who got on their own medications and they walk miles every day and they live a very independent life. But when they want to come into hospital, when they can come with any medical problems, but the commonest ones are falls and confusion. And as I said before, these are markers of biological systems failing. But most importantly, they can come with just non-specific symptoms. Nothing, feeling tired, off food, just taken to bed. People have the very unsavory name of off legs, where if you look at it and say, but they got no particular, they're not coughing, they got no chest pain, they're just tired and taken to bed and not eating. Because these are manifestations of diseases. And how frail you are depends on how easy you have to manifest those diseases, as we'll see as we go along. So as you get older, I mean, if you put everybody on a pedestal of age, and so people are going to get diabetes at 60, if you let some other people carry on till 120, they'll still get it at some point in time, because these are all diseases as we age, and there are deep reasons of why they happen. A lot of it has got to do with the fact that as we age, we had a dysregulated immune system. So inflammation is a very big part. And that was also noted to be one of the markers of COVID vulnerability. So those who have unstable diseases at younger ages were more vulnerable to the disease than those who didn't have it, because they were all having the same grandmother, which was aging process. You say some people age faster, some don't, and so a lot we can talk about that. Now, let's talk about falls, which is a very significant aspect of coming to hospital. It's costing the NHS a lot of money, about $2 billion a year, so the records say, and there's a lot of causes for that. Many of it are internal causes, so intrinsic causes. So people have more internal diseases, diabetes, hypertension, joint problems, they got dizziness, they got low blood pressure, but they're also extrinsic, the environment, the flooring, the lighting, and stuff. Now, it could be quite simple. They fall, get up, no fractures, they walk again, they go home. But it could also be a manifestation of severe underlying disease. And in elderly medicine, if somebody who is normally robust, walking about independently, starts having falls, you need to start looking for something very serious. And many at times, that's when you've picked up cancers as well. But I'm not going to say here that everybody has had cancers. Please don't quote me on that. But if somebody who is walking independently and has been fine starts falling, that's a very bad sign. It is like a fever in young people. It's a symptom which we need investigating. And in most time, all the times, it needs a multifactorial assessment. Now, what does your walking reveal? Something which you take very normal that I just walk, but it reveals a lot about who you are, your energy level, your balance, your control of movement. Your control of movement depends on your nerves, your joints, the muscles. It depends on your nervous system. It depends on your breathing, your heart. So when people are slowing down, even in mid-age, that's not a good sign. That's a sign that their aging is accelerated. We know, I mean, there was a BBC, was it BBC or was it on Metro, picture of Metro where they showed that the strength of your grip determines how long you could live. We've known that for quite a long time. In elderly medicine, we use what they call the hand grip dynamometer. So if your grip strength is not very strong, these are all manifestations of you slowing down or aging faster. So in elderly medicine, we would do what they call the get up and go test or the get speed, where if somebody walks 4 meters longer than 5 seconds, that's significantly showing that you're slowing down, which means that's accelerated aging. It's something to work on. But now fall can also lead to very severe consequences as well. Something which we think could be trivial to actually cause people to die. And most times the family to come to hospital and we're like, I don't understand. My mom only fell and then she ended up dying. Many a times because what caused her fall was multiple interacting complex medical problems, and that was just the last harbinger. That was just the last manifestation of that complex biological systems failing. It also led to many major trauma. Now we got trauma centers in the UK. Back in 1990, major traumas were mostly due to road traffic accidents in young people. But nowadays, you're getting almost a quarter to a third of the people attending the major trauma centers are older people, and they're falling with just simple falls at home, falling at a height less than 2 meters, tripping on the stairs, falling on the pavement, and having major trauma. And the one we worry about as well is not just bleeding in the brain or bleeding in big organs, but also neck of femur fracture. Because if you fracture your neck of femur, your chance of dying in 30 days is about 10%, which is very high. And sometimes you see our GPs who not really want your blood pressure to be hovering on a very low side, because if you are trying to keep blood pressure too low and the patient stands up and goes dizzy and falls and fractures the femur, what you were trying to prevent a 5-year mortality of about 2-3% would turn it into a 30-day mortality of 10%. So which means that it needs to be holistic management. Also importantly, falls lead to significant psychological problem, because when people fall, they develop a fear of falling. And that means therefore that they can't do the things they were doing before because they're afraid to fall. I mean, it's embarrassing to be falling on a bus stop. And so they don't go out. The quality of life now diminishes and depression could set in. And there's something we call PJ paralysis, pajama paralysis. They could just be sitting in one place. If you've been on elderly care ward, you see, we try to move our patients around a bit more, because just sitting down could actually cause you to decondition significantly. We saw that with COVID and the lockdown. Many of our older patients who were home, who were in lockdown, either because they were shielding, deconditioned significantly. That falls became a very big issue after that. And one thing I want to also talk about is delirium. Acute confusional state is a very common manifestation, and we see that quite commonly in our hospital. Many of our patients' relatives would have noticed that when mom gets a bit of water infection, she goes a bit dolary, she starts saying a few gibberish and stuff. That's how they will put it, which is right. But sometimes it could also be a manifestation of a very serious underlying problem. When I say to people, somebody's got heart failure, they get interested, or somebody got kidney failure, they get interested. When somebody got delirium, they're like, oh, okay. But delirium is actually a brain failure as well. So it has significant mortality. And when patients have it, or when our relatives have it, we need to look at the other Ds. The 3 Ds could come together. It could just be unmasking underlying dementia, but it could also be confused with the depression. So we tend to look at all of them at the same time. Now, all these things are just showing that the patient is now, as the patient is aging, or as the individual is aging, develop that vulnerability to decline. So the various organ systems have been diminishing. Some of them are not reach the point where you say it's a kidney failure or it's a heart failure, but when you put all their diminishing together, it leads to a reduced functioning in the individual, and we call that frailty. And you will know that by how they walk, how they easily get tired, how they sometimes could lose weight unintentionally. But we could also look at that by seeing the amount of things that they accrue as they age. As I said before, we age by accruing deficit, what we call deficit. And deficit will be defined as in comprising 3 things. 1, it gets worse with age. 2, it doesn't saturate easily. And 3, it leads to a worse outcome. So for example, as we get older, we're more likely to get arthritis. Now, so it gets worse as you get older. It don't saturate easily. So not everybody that gets old gets arthritis. 3, it could lead to a worse outcome. It makes it easier for you to fall, causes pain, and possibly depression. So as we're growing older, we're picking up all those deficits. And when you add them all together, you could now say, for example, somebody's frailty index is getting higher. It affects all the body organs. But the good thing about it is dynamic, which means as it gets worse, which is the highest possibility of getting worse, but it could also be reversed. And there are things that we can do about it, which we'll talk as we move ahead. But I want to bring about the frailty fulcrum, because sometimes we talk about the medical bit and we forgot to understand that actually, as we age, there's interacting complex medical and also social and psychological problems, what they now call the biopsychosocial model of aging. So you have to consider all of them together, not just the physical health, not just the mental health, also the social circumstances and the psychological circumstances, the environment where they live. They all interact together. For example, you could be having no medical issues, but you're living in an environment where there's poor access to facilities, there's maybe rowdy neighbors and a lot of racism and microaggression in your streets and stabbings. That definitely brings down your psychological status and pushes you into becoming more overall frail. Now, what some people have tend to do, some authors have tend to do, is to try and break down frailty into various components: social, physical, psychological. But if you consider that we're aging as a human being, then one aspect could actually affect the other aspect. We know, for example, and these studies have been done a lot across the board and here, that where our people suffer from racism and aggression, they have a higher chance of developing type 2 diabetes and heart problems, which means, therefore, that these social issues are tied with their psychology and it's tied with their physical health and, of course, with their mental health as well. So what data says about Afro-Caribbean people? That we report poorer health, and these are all quite documented. And we also report poorer experience in using the health service. We know that, and we can't pretend to say that it's not been said before, that the NHS is institutionally racist. And I hope that that's changing for the better, what it should do, and I think it is doing. We also know that we have a high prevalence of cardiovascular disease and diabetes, and high level of socioeconomic deprivation, of course, with the structuralism I've talked about. Now, with all this, you would expect, therefore, that our level of frailty as a community or as a people will be higher than others. But no, a recent study done in London looking at, now, when I was talking about frailty, one thing I didn't talk about was how you measure it. There's something called a frailty index, where if they can take 30 things and measure, if you have 5 out of that 30, there's your index is 5/30. Now, some clever doctors have done some measurement where you can do that with the GP, the data, the GP surgery. So you don't have to get the patients and do any measurement. You don't need to go on the GP records and you can get it. They call it the electronic frailty index, EFI. Now, these authors went to these surgeries in London and took out all this data for these patients and categorized them into Bangladeshi, Black, Indian, white, and Pakistani, and try and look at their electronic frailty index. Actually, the Black patients were the ones with the least frailty of all of them. Now, though it sounds quite good and nice, I want to say it with a pinch of salt as well. This was a data that was taken at one point in time, so it wasn't data that has been looked over time. And secondly, we didn't know in sociology that there's something called the stealing effect. So if you do, they used to say, what doesn't kill you makes you stronger. If you take somebody and you give them a bad, you do something not good to them, some people actually come out from there stronger than they were before then. And so this might just be the people that have survived it by the stealing effect. But be very careful, because you can do that same thing to another person and you sensitize them and they go down. That persistence in doing bad things to them could actually cause them to decline in health and actually die. So we might be seeing those who survived it, but have missed those who did not survive it and probably either left or died a few years ago. But by and large, the question here is, how then can we develop ourselves in such a way that we develop, which I will now call a resilience? Now, I'll be talking about frailty, which defines the vulnerability as we age. The negative side, it doesn't have to be. There's also a capacity to age better, and that capacity what I'll define as a resilience, the ability to withstand the storm when it comes, or even when you fall down, you get back up quicker. That is what actually defines the future of aging. And this can be on a spectrum. The same things, remember the frailty fulcrum, the same things that can make you go down and become frail are the same things where if you use them positively can make you become resilient. And that's where what you now call successful aging is being redefined. Back in the days, in the 60s, successful aging was seen as you growing up, getting into work, working, maybe having a family, and then in your mid-50s or 60, you retire, and then you live active work, you live active social life, you go to live to some old people's village and do your fishing and let the younger ones now be involved into active social life and political life. That was seen, if you do that, you're said to be successfully aging, but that's changed now. You're seen to be successfully aging is when you're still getting up and doing the things that you were doing when you were younger. You're still very active. So that's what the activity theory is on. I take an issue with this because it sometimes means that somebody who is not doing it is not aging successfully, which is not true. I tend to define it, and that's my opinion, as you age on your terms. Because sometimes even people with comorbidity, so for example, somebody who had a stroke and can't do this dance, can still enjoy life by optimizing other aspects of their lives. Now, the active aging actually is a policy thing that the government is trying to institute, all over the Western world, where they're trying to get people into employment to stay longer. They're trying to get them participate into society by volunteering. And just why on volunteering? Just by being a volunteer have been shown to increase their life expectancy, the remaining life expectancy by about 40%. So it's a very important thing to do. So all these are being taxed in the active aging index, just like a human development index, to see how people are living lives on their terms. But let's come back to the frailty fulcrum. Because most times when we do speak as doctors, we just talk about the biomedical stuff, the diabetes and the hypertension and the hospital stuff. But a lot of these are also intertwined by not just the system of care, but also the social environment and the psychological environment. I think my psychiatric colleagues will always talk about the principle of parity of esteem, which says that your physical health cannot go without your mental health. Both of them have to go hand in hand. So no health without my mental health. Now, the system of care is quite important because that is something where you could have the best system in the world, but if it doesn't deliver the amount of care to a certain category of the population, then it's hopeless. And that's where the issues of access is very important. That's why issues of structural racism is something for everybody to fight against. My personal opinion is that it is not just an issue for Blacks or any minorities. It's actually a wide issue. But this structural care has to do with your GP, who should be a first port of call, the social service. And while the NHS is one, and you can get similar things around the world with some few episodes of postcode lottery, elderly care medicine also depends on social care. And social care depends a lot on the councils, and the councils do vary. So here where I work in Mid Yorkshire, we're covered by Wakefield Council, Kirklees, and Leeds City Council, and the three of them offer different type of services to older persons in the community. So those of you listen to me from all around the country, it might be different in your area. However, the principle is the same: to deliver health and care nearer the nearer home and the best way possible. Now, I did talk about the social and psychological factors. I did talk about relationships with families and friends and the community. The reason why resilience, I don't see it as just an individual perspective, but resilience is something that actually is community oriented. So the community together has to foster each of their own resilience. And there are different models of this. You can see, I mean, there's a physical health, and so CAHN has talked about that a lot of times in their webinars, the diabetes control, the high blood pressure control, exercise, nutrition, and all those things we talked about time and time again. Psychological health, mental health, we talk about time and time again. I think also trying to understand individual factors is important. People's ability for self-reliance, self-efficacy, the ability to believe in your own self that I can do things for myself and get that self-esteem of doing it. But that's very important to also take note, because when people who have this self-esteem and self-resilience, when they have any catastrophic health problems, say for example, they have a stroke and they cannot do this again, if you're not careful, they get quite withdrawn, depressed, and just go downhill. So engaging them has to be who you're engaging with. That's the more reason why in elderly medicine it's very important to get the collateral history from the family or the significant others, because you will tell who you're dealing with. But two things I want to emphasize and take that further is optimism and the importance of a social network. Now, studies have done in America survey data where they looked at people right from the 50s and 60s. So every year they're asking them various questions, their habit, their smoking habit, drinking habit. They're doing a scale called the optimism pessimism scale. So you can see who is optimistic and who is pessimistic, who just have a good outlook about life, you know, hope for the future and stuff like that. And across all survey data, it is shown that those who have more optimistic outlook of life actually live longer than those who don't, even if they have the same diseases. So they look at them further and they picked up those who had lung cancer, and they look at them with the same type of cancer, the same level of spread. Those who were optimistic lived about 6 months longer than those who were not optimistic, those who were pessimistic. We know some people are just being not quite sure about the future, they're quite pessimistic about the future. But it's been shown that even if that optimism is not a true optimism, well, of course, I'm not saying believe that you're going to fly from the high building and you survive anywhere, but having an optimistic outlook of life has been shown to actually lead to longer life expectancy. maybe I need to try a bit more optimism as well. Now, one of my subspecialty interests in elderly medicine is orthogeriatrics. Orthogeriatrics is the part of elderly care medicine that works in conjunction with the orthopedic surgeons to look after patients who suffer from a hip fracture. Because it was found many years ago that patients suffer from a hip fracture and they have the hip fracture surgery, but quite a lot of them die. They didn't die because of the complication of the surgery, no, they died because of the medical complications. Like I said before, people could be falling because they got a lot of medical issues wrong with them. So they found out that when we get elderly care physicians involved in those patients' care, they improve survival. And so that's where orthogeriatrics as a subspecialty came on from. And I work on those departments. And we see people who are 60 years and above who had a fall and had a hip fracture. And there are some people who, even at 90, they'll be very optimistic, upbeat, and just say, like, don't get on with it. But there are some who are quite younger who are just pessimistic about it. The optimism has been shown to recover from hip fracture significantly. And there was this study done in America on this same hip fracture patients. In fact, they did it for a PhD. And apart from all the medical issues, she found out that just being in your home, having a faith in God, determining yourself to get better, and having the ability to participate in meaningful activity or having a good optimism led to a better outcome. And so I cannot emphasize being optimistic much enough. Now, we also known that not having a good network is very bad for health. I mean, there are some people who prefer, that's a choice, not, I want to be by myself and trust my dog and stuff like that. But perceived social isolation has been shown across the board to lead to a poor outcome. So when we ask people sometimes what the leading cause of death, people will say cancers and heart attacks and strokes, but no, lack of social connection is actually another major killer. And what do we mean by that? Those people that you can count on when things are not good for you. This study, which I'm actually quoting now, was published last year, and it was done across the world in high-income country, medium-income country, and low-income country. Actually, it was done in Zimbabwe and Zambia as well. And what they did is they took a lot of people and they asked them a question. There were 5 of them. Were you married? Can you count on your family in difficult situation? Can you count on any organization in difficult situation? Are you a member of a religious group? Those kind of networks that support you. Those who were scoring 4 or 5 out of the 5 questions were said to have a significant social isolation. And the study found that actually it increases your chances of dying by about 26%. That alone, not talking about the medical issues about it, just the fact that you're socially isolated. And why is that? We've known from people suffering from racism that the reason why it causes significant problems with your heart and other chance of getting severe diseases because that persistent stress leads to increased stress hormones. And the same thing that was also found here, that when you're socially isolated and you become quite anxious about the fact that society could be evaluating you negatively. I mean, where I come from, they used to always say, it's only a wizard who eats alone. That might not be true anyway, but that's the kind of thing that, I mean, our forefathers used to say. And when you find your environment not trusting and it seems like it's threatening, that leads to 2 things. One, increased stress hormone, which has got significant negative connotation, and also decreased immune function. And so building a strong social network has been known significantly to increase resilience and people's quality of life and length of life as well. Now let's come back and talk about an older person coming into hospital. Well, if you have any significant single organ disease, of course, you go to the organ specialty. But when you do come to an elderly medicine ward, you get a few assessments. Of course, a comprehensive medical assessment, a comprehensive mental health assessment. You also get a frailty assessment, in which case we try to relate with your significant ones, your families, to see who you were. And so we can know how much you deteriorated from there. And elderly medicine is practically a multidisciplinary team involvement. So it's not just the doctor or the nurse that will be managing your care. There'll be a lot of other especially the physiotherapists, the occupational therapist, the dietitian, the social worker, who always meet together to make sure we're delivering the right kind of care. And the idea is to get you out of hospital, either home, if you're able to go home, even with some adaptation, or to a facility where you can be assessed further to see whether you can go home, you can go into a 24-hour care facility. Then, of course, with all the adequate follow-ups. That's the dream, to get every other patient coming to hospital, get the best care, and then go home. Most times, well, not so most, sometimes it doesn't work that way. And sometimes, because it is a specialty that deals with a lot of other people, there's always chance, or there's sometimes chance that there could be miscommunication. And that's why I always encourage the family to get involved in that conversation to make sure that things are in the same place. But at the same time, and as somebody once asked me, how long are you going to keep it? How long are you going to be keeping people alive? So when nature decides, the hospital is not just a place to get people cured. Sometimes it's also a place to make sure people die a good death, if there's something like that. And so sometimes it don't go the right way, it goes the other way. And when somebody's in hospital with a serious illness, we tend to ask 3 questions. How do we treat this individual? How far do we treat the individual? Now, in the hospital, there are various levels of care. When you're in a normal ward where there's one nurse to like 13 or 14 patients, we call that a level 0 bed, which means that you cannot tell the nurse to be doing observations every hour because you've got 13 other patients to see. You can escalate that up to level 3, which is intensive care, where you can actually put the patient to sleep and take over their breathing. Now, when our elderly people are unwell in hospital, there are a lot of things that we're going to look out for. One, who are they? So if somebody who's had, say, a pneumonia and is 75, for example, and lives alone at home independently, goes on shopping, does her own cooking, and sometimes even drives, takes 1 or 2 medications, it's not the same like another person who's 75 and got kidney disease and got heart failure, works with Zimmer frame, 10 yards maximum, needs 4 times carer a day. So that has to actually inform how far we treat this patient, whether we're going to go to a level 3 bed or we're going to keep the patient on the level 0 bed. Those are very significant conversations in which the team will always try to discuss with the patient's family. We always have to discuss with the patient's family, especially when we're not starting making decisions about what will happen. Sorry, there's some recording coming on.
Yeah, I think it's resolved now. Thank you so much.
No, especially when we start talking about what happens if the patient's heart stops and they discuss about gaining CPR. In my experience, I found this discussion not going down too well with our community, and for obvious reasons as well. This is a community that has suffered significant structural racism and microaggression through they distrust the health service. So to have these kind of significant conversations, you really need to spend that time. And that's why I'm not a fan of health equality. I'm of health equity. So if 2 people are coming up and one has been dealt a bad deal over the years, then you have to spend more time to make them understand where you're coming from, because you're going to treat somebody who don't understand their beliefs, their concerns, and their expectations and stuff. But it is very important that family engage this conversation because, like we said, there are 2 important episodes in your life: when you were born and when you die. So you want to assure that when the person is going out the best way possible. Most times what we will do is we'll have that conversation. If the patient has got capacity to make that decision, we'll have the conversation with the patient. But if the patient hasn't got the capacity, then we can make that decision, but inform the family. And this is where it gets a bit tricky. Some people say sometimes that it is a medical decision. No, the family has a say. So if the family don't agree with that, and it's quite enshrined in our guidance, then you have the right to ask for a second opinion. And I always encourage family to engage with this, because at the end of the day, 6 months down the line, medical team might not remember your relative's name, but that episode is something you're going to carry with you throughout your life. And so it is our practice, and I'm sure a lot of my colleagues across the country will be doing this as well, to always engage family as much as possible at this final moment, so that they start getting closure, because without that, they won't get closure. And that's what I'll say about that. But I was talking about resilience, and I was talking on the good notes, and I came to the other part of what happened when things go wrong. But some take-home points. We cannot only define aging by the negative side of getting old or getting old. Like some of my patients always say, oh, it's not fun getting old. You know, you're getting all the pains, and you can't walk, you can't do things for your own self. But there's also a positive side of getting old. And the trick about it is get to that old age in a better form, then you'll be able to carry on doing the things that you want to do. Now, it's very important for our community to understand that, as we always say back in Africa, it takes a community to raise a child. It also takes a community to look after an older person. Because the resilience that they're going to develop is not just an individual one, it has to be coming from the community itself. And that there's always support in your community, no matter the level of function that you are. I always encourage the family to discuss with the various data of the teams that are looking after your relatives' health. Thank you.
Thank you so much, Dr. Ngwa. That was fantastic. If I can ask you to stop sharing, and then we will go into the questions. As I always say, I always learn so much when I come onto these sessions. And I think that you said so many great things. And the concept of what our age is, and it means different things to different people, but also just thinking about how we actively age, and how we can, and what influence that we have got in that, and also our networks as well, with our village supporting us. So that was really fantastic. Thank you so much. And you broached an area that I'm sure is going to come up more, but it's something that's really dear to my heart, is those conversations near the end of life, and how we can make that better. Because I know in experiences in my life and friends and family's life, is that when those conversations don't happen, it can be the most painful experience, because you feel you didn't have any ownership of it, and you feel that that member has failed. But actually, if you have those conversations, it can be transformative in how you process that. So thank you for not shying away from that topic as well, and bringing that to the forefront. So I'm handing over to everyone in the audience. This is your opportunity. We've had a fantastic presentation, and I know a lot of it will resonate in our lives and those of our families. So please do bring your questions forward. Some that have already come through, and reflections. I just wanted to pick up on one reflection, and thank you, Angela, for sharing, highlighting the effects of social isolation. And I think it's often underestimated. And Angela shares, and I'm sorry to hear of your losses, but saying that her mother's health started to deteriorate rapidly after her father died, unfortunately. And I'm sure you can comment on that, Dr. Ngwa. I'm sure you've seen it in many cases, but it's something that I see quite a lot in work and also in the community.
Yes, absolutely. That's the widowhood effect. It's been shown time and time again. And I mean, it's very beautiful to see couples stick together and do things, but the preaching is they should not be away from community, because that community that will be able to give that support structure when one of them goes. Without that, if one of them goes, there's a chance that in the next 3 months, people are so I thought to actually say it could range within a year, it could range from 30 to 90% of the other one going as well. And so yeah, that's the widowhood effect, which has been noted in sociology.
Great, thank you. And a question that came up about is there a list of online Zoom events or activities across the country for Caribbean and African elderly, older age people? And I think our colleagues at CAHN and CATHIP, I'm sure, have a list of some events that go across all the organizations. So I'll kindly ask colleagues to perhaps share that online, or perhaps if you'd like that information, you can, we'll give you the email to contact. But also, Dr. Valentine, it'd be great to hear if you know of resources, because something that struck me is you put up the framework that is used in the NHS at the moment. And I think that, like many parts of health, we as a community need to know what the NHS is working to, because then we can develop interventions that are more relevant to our communities. So I think that's really important. So are there any resources that you know of, or you suggest websites or things?
Not the top of my head. I think that's something I'll actively look and I'll bring back to feed to CAHN. I think you're very right. We definitely do need that. And a few weeks ago, we were having this conversation about how we're not pulling it towards our community and getting become like the vanguard for our community in terms of making sure that we're speaking for them, for our community members who are in hospital and they might have cultural differences in understanding what is going on with their own care. I'm sure going forward, there are going to be a lot of things coming up, particularly now that we know that the NHS is actually admitted with the COVID about the health inequality, that there will be a lot of things put in place. And I'm quite sure, and I'm quite aware that there are quite a few colleagues of ours from our community that are quite engaged in that conversation as well. I would definitely be seeking more information and feeding them back to yourselves. Yeah.
Oh, that's incredibly kind. That's fantastic. And I don't want to put Avetta on the spot, but in the chat, she's written that they've seen positive effects on their elders at their weekly luncheon club and exercise class. I don't know, Avetta, if you are able to speak or write in the chat the name of your club, etc., because I think, again, that's why we're all here to learn how we can support. So please feel free to come off mute and speak, or you can put it in the chat. Oh, okay, thank you. You're a step ahead. So Avetta says that for people in Enfield or the North London area, they welcome elderly people to join their club. So again, I think we'll put all these resources together so people can learn more about it. That's great too. So there's lots of questions coming through in the chat, which is fantastic. I'm going to give people an opportunity that have put their hands up. So I'm going to hand over to my namesake, Vanessa, who has her hand up, if you'd like to put your question through.
Thank you very much. I'm rushing off to work, so I just wanted to make a quick comment. Thank you for the presentation. Excellent. I'm a nurse by background. That's why I'm rushing off to work. But the key take-homes here are physical well-being, psychological, nutrition, and exercise. Everyone is an individual, and you are the owner of your own well-being. When you enter the NHS, what you should do is be asking questions. How does this investigation or treatment, what will it mean for me? And those will answer a lot of queries. I love the tie-up with end of life as well, because again, that's a conversation that many people don't have, and they wait until the person is elderly, frail, or got dementia, and they don't know what that person wants. And it's difficult, it's still taboo, but it's an important conversation to have. Fortunately, I had that conversation with both my parents, and I knew exactly what they wanted. I had a recent experience with a brother that's in his 50s, and they were going to put a do not resuscitate order in place. And the conversation didn't go very well. And that was 2.5 years ago. And I truly believe, had that been put in place, my brother wouldn't be here today. So it's important to understand and ask the right questions, but also understand what the individual themselves wants. Do they want to be resuscitated if this particular condition deteriorates? So it's understanding the individual. So it's important for our people to have those conversations. I do get the mistrust, etc., but going forward, there's lots in place and lots of support. We've got CAHN, we've got lots of other areas, advocacy, where you can ask those questions of people that you trust. And that's just what I wanted to say.
Thank you. You're very right. You're very right. You're very correct. Thank you so much for that.
No, thank you. No, those are a really great reflection and comments. Thank you so much. And I hope work's okay as you go off. Thank you. Elsie Sutherland, would you like to speak now?
Yes, thank you. That
Perfect.
was very, very good presenting. My name is Elsie Sutherland, work in social care and health for years. I'm retired. I'm still very active in the community with CCG, Health Watch and everything, PPG. But what I really is saying here now, and listen to what you're saying, it's very good when we have these meetings and some already made up their mind what is going to happen without the people involved, the older people. So we need to have words with them. And not in the terminology. It depends on the word, how you use your word, and the culture. It's language as well, how you use the language to meet these people's needs. I found that right now I'm involved in a project that I was help tendering for discharge from hospital to the community, NHS Health, England. So I'm on that project at the moment. I found that with older people, it's sometimes stereotyping and labeling because you have an arthritis. This, every time you go to the hospital or the GP or whatever, that name to you because you have that. They're not looking at the causes, the preventative side, and things like that, and the involvement of families. I might say that for families, a lot of families living far away, and someone talk about isolation. Sometimes people don't like, because of their dignity, they don't like to go out, they don't like to speak to people because they're so private. How do we reach? So we have some people we don't reach. I'm very pleased that you brought this subject up for us, older people, because older people seem like they put in this box. We are not. To look at resources, yes, you have Age UK, and we have used to be Age Concern, Age UK. You have the BME Forum that comes on the platform and the Zoom every Wednesday at 3 o'clock. And we have different speakers. We have people who talk about the power of attorney from the Age UK and how things are. I just had a daughter, 55, passed away. So I was involved in May in a funeral, which I haven't been involved in a funeral from when I was a kid. I just have families passing. But when you got to do it and burying your child and the neglect from hospital as well, that didn't help at all. I do the place assessment at the hospital. I inspect Croydon University. So I think a lot of people say, I could see 86 names, but I think we are all over, wider, the same as the group I'm on with discharge. We all speak different language. They are not in the same as us, the privileged ones. Some privileged, some not. So really, I just want to say, it's a lot of clubs out there. If people are aware of them, and as I say, if you have a list, but there's different areas. I don't know which area you are in. Sorry, thanks.
Elsie, thank you so much. You said so many wonderful things there. And firstly, I just want to publicly say just so sorry for the loss of your daughter and what you had to go through in burying her. But I just thank you for everything that you shared. And I'm sure Dr. Valentine has things to comment on. One thing I will say is what you've highlighted, which is so important, that is aligned to this, is you are on so many groups within the hospital and the NHS, and that is wonderful because that's what needs to happen. We need to have more people like all of us on those groups to influence. So I just also want to thank you for, representing us, because every person of color that goes to those meetings represents us. So thank you so much. Dr. Valentine, I don't know if you've got anything specific you want to add on to that.
Yes, and again, I'm sorry to hear about your loss. I think one of the things I ended up with was saying that it's that was just me taking it from the other proverb, that it takes a community to look after an older person as well, and we all have to be responsible towards that. And I remember when it was the COVID time, we were talking about COVID vaccine. The reason why many of us were coming out and talking about the COVID vaccine was because we wanted to be seen. We wanted our people to understand that those that look like them are also involved in this. That's what they want saying. And I think it goes a long way as well to be able to advocate for our society, our community. It's very important for me to hear that you're getting involved in that. And I think that's something I'll encourage everybody to get involved, no matter what level. Now, one thing in which you say medical care is not the same like healthcare. Medical care is about 20% of healthcare. So there are a lot of non-medical people out there who could deliver fantastic healthcare as well. And that's one thing I keep saying. If we want healthcare, I mean, I've talked at length here about the social and psychological factors. So there are people out in our community who are also sports enthusiasts, there's dietists and nutritionists, the coaches, and they could also be involved and build that resilience. I think it's the community who has to build that resilience together.
Very well said. I mean, I did, if you look, and I had a lot of people. I had a vaccine video.
Yeah.
I did a vaccine video because my friends, and when I done that video, so many of them who didn't want to take the vaccine, they went to have the vaccine. Because why did you have it? So I had a lot of questions. Why did I have my vaccine? So I just expressed. So yes, it is a community who builds the whole of the world, really. Where you live, how you look after each other's neighbors. And neighbors is not just your neighbor across from you or wherever. Neighbors is everyone around you. Thank you.
Oh no, thank you. And what a beautiful statement to end on there, Elsie, and a reminder for all of us in all we do. So again, just acknowledging you and thanking you, truly, truly valued. And I wanted to bring up, because this conversation about supporting people to live their best life, but also supporting people nearer the end of life, as we expected, has touched many people. And I just wanted to highlight Dr. Asante, thank you so much, who has just brought up a comment and asked to have additional thoughts on it. So Dr. Asante writes that she's a GP with a special interest in frailty and elderly care, and speaks to patients and family regularly, like you, Dr. Ngwa, about anticipatory planning and end-of-life care, and agrees that especially involving family and next of kins in this discussion helps to have a positive effect on which is otherwise a really grim discussion, and highlights something that is so important about kudos to the seen and unseen carers looking after their relatives. Again, beautiful, because they need support too. And so advocating for sharing local carers support services. So thank you for that, Dr. Asante. And then Dr. Asante also says, Dr. Ngwa, are you able to please touch on the respect document too, for the benefit of our viewers?
Yes, it is. It's something which is not used in all the trusts, but it's a document that is absolutely necessary, because it just details what we've been saying, what the patient's wishes are. And so when the patient comes into hospital with that document, you already know what because they've made that document at the time when they're in the right frame of mind, what the kind of things that they would want doing and what they wouldn't want doing, including resuscitation, including doing some invasive procedures, the kind of likes and dislikes. And I think it's very important document that at a certain age, people should try and have that conversation and have one of those documents put through, because it just makes your care so easy once the team that you come into hospital, picks up that document and see the kind of things that you wanted and one you didn't want. But don't forget, sometimes you could actually be brought up to an emergency where we can't reach a family member to actually say what your need or what you wanted. So that document would highlight to us who you are, what your likes are, what you've agreed that should be done to you, and what shouldn't be done to you, so that your teaching team will be able to deal with you on your own terms. And I think that's one thing about getting older. We want to get old and even end it up on our own terms.
Thank you. That whole ownership and on our terms is so important. Bev has written what is the name of the document, where we can get it from. So I'm sure that one of the team, Bev, will just put the full name and how to get it for how to get access to it in the chat for us while we're speaking. So someone asked, is there a process where a decision not to resuscitate is taken out of the hands of the family? And if so, what are those circumstances?
Right. And thank you so much for this question, because this is a question I've had a lot of discussion with my juniors about. There used to be this notion that it is the medical, so somebody cannot give you consent, so it's unable to consent, because the law in England says you cannot consent for another adult. So if somebody cannot give you consent, then that decision is a medical decision, but it's not true. The JMC guideline on that is it's always good to involve the significant others. And of course, how you have that conversation is very important, because it will depend on those significant others, their belief, their understanding of what a resuscitation is. Quite a few people think that it means that you're stopping their life. No, actually not. It's not. It means something else. But if they go along with you, that's fine. If they say, no, I don't agree with you, what the JMC says, there's a way you can actually resolve this. And you can do this by, 1, getting a second opinion, or 2, getting a mediation. So if I have that conversation, and there's been times where I've had a conversation and the family say, though their mother cannot speak to me because she's either probably drowsy, and the family says, well, no, I really don't think that you should put a non-resuscitation for it. You'll get a second opinion. You get a colleague of yours, most probably the one who is more senior to you in experience, to have that conversation with them as well and get a second opinion. And if they agree with you and the family still insists, that you can now get a mediation. The hospital can provide a mediation. The ethics committee is there. And you cannot just take it out of their hands like that. In elderly medicine, it's unlikely that it even goes to the court, but you will know that in children, it could end up in the court, where they want to debate whether that decision is right or wrong. I'm sure by the time you have a second opinion given, in fact, they've been telling me I have to go for a third opinion, the family by then would have been able to come around and understand what the whole process is. But oh no, and I think JMC will stand with me on this, that you shouldn't take it out of patients' relatives' hands and just say, well, I'm my decision and you have nothing to say about it. That's a bit paternalistic. And I think that people deserve the right to have, if they want, a second opinion.
Thank you so much. As I said, I'm really glad that question has come up, because I know that is something that comes up in, family members ask me that question as well. So thank you. And there's a question I think many people will be thinking of, just because you mentioned it, is about biological age, and how can you find out what your biological age is, and also how can you reduce it? Is that possible? It is absolutely. That's one of the parts of resilience, which we're talking about now. It's how you find it is difficult to say. The reason being, the models that have been done were done with a different community. So if you go to any of these Bupa machines on the bike, and they'll say to you, oh, your long age is 77, and remember you're 60 and stuff like that. But that modeling was done with a different kind of population. What we use most now, which is coming en vogue, is the electronic frailty index. So they could say, for example, you're expecting an AFI for somebody who is
chronological 60 to be around that age. But if say 0.5 to be around 0.5, for example, but if you are scoring say 0.6, then they'll say, oh, though you are 60, but you are scoring the EF of somebody who's about 75, which means they're aging a bit faster. That's one way of finding out. And how you can reduce it, it's now even in frailty, the what has been shown is what they call prehabilitation, which we know about rehabilitation, but which they use a lot for cancer medicine, for cancer surgeries. It's exercises, it's nutrition, and of course, it's quite important that older people get this with the help of nutritionists, because you get the wrong nutrition, you lose more muscle, and you lose more muscle, you have what you call sarcopenia, which is how frailty manifests in the muscles, and that actually worsens things. So yes, the environment, your stress level, your exercises, particularly resistance training exercises, building muscles and weight and stuff, your nutrition is very important, protein-rich nutrition, and the other things as well. Just your mental well-being. If you're in a stressful environment, of course, you want to try and avoid those kind of things. So those are all, remember the frailty fulcrum I showed, all those aspects do count. And as I said before, biological age is one of the ages where you can reduce. Chronological, you cannot.
Thank you. I think you've also highlighted something that many people are thinking of. And Faye kindly puts that for us to please attend our the CAHN's Healthy Heart sessions online each Tuesday to improve your biological health. And I'm sure that Laurenti, just as we finish, will be highlighting that as the session is closed. So thank you so much. And one of the things that has come up is that someone comments that you talk about the most important events, birth and death, but also wanted to just have your thoughts on why the health system appears to focus more on events at birth rather than old age, and there doesn't appear to be as much investment. What would you say to this?
The health system was traditionally built for people with single disease coming to hospitals. The health system was people with, you come with a heart attack, you got your heart attack dealt with, you come with diabetes, you get it dealt with, you got a pneumonia, you get it dealt with. But now the kind of patients we're getting walking through the door are not people with single organ problems. There are people with multiple interacting medical problems. It's complex, and complexity needs thoroughness, and thoroughness needs staff and commitment. And so it's something with the system is gearing itself towards getting, for example, getting an elder patient onto our emergency department is a tragedy by itself, because you can imagine our emergency department is bustling. There's a lot of staff coming and going. There's a lot of noise, a lot of light. They're hyper-stimulated. By the time they spend 4 to 6 to 10 hours in there, they come out more confused than way before. These discussions are happening, and I wholly hope the funding will carry on with that. But at the moment, the NHS is struggling from physicians for elderly medicine significantly. I think the last time I saw the data, they were working at about half the capacity. So they need to build that capacity as well, and then change. New systems are coming up. They're now building setups where patients don't have to come into hospital to get treated. Patients can be seen at home. They're expanding community inreach into things like that. So it is not where it should be, but it's definitely improving significantly where we want it to be.
Perfect. Thank you, Dr. Ngwa. You're so right. I always say the system was built for the majority at that time and not for the minority, and life has changed significantly, and a lot of it needs to be done. As always, we're packed full of questions, and I'm going to give Llewellyn and Faye Green, just if they could quickly get their comments through, that's great, so that we can bring the question and answers to an end, and I'll hand over to Laurenti. But as I predicted, this has been a fantastic session with great engagement as always. So Llewellyn, if I hand over to you, if you could briefly give us your question or comment. Thank you. I think, Llewellyn, have we lost you? Okay, Llewellyn, whilst you're, we're still aiming for you, we'll move on to Faye and then see if you can come on in a second. Thank you.
You need to unmute yourself.
Sorry, Faye, you can unmute yourself now. We've just unmuted, asked you to unmute.
I think you're on mute, Dr. Vanessa.
I love it. Thank you so much, Lorenti. Faye, while you, Faye's
Hello?
unmuted.
Can you hear me now?
Yes.
Can you hear me? Okay. I was looking at what you said earlier, and I feel that people of colour have suffered racism from the time they're born. Now, we've got this from the time we're born. It's in school, it's in nurseries, it's in the workplace. How are we ever going to eradicate that, get rid of that, so we can live a normal life like Caucasians in this country? I mean, we're doing all the exercises. I'm a 70-year-old retired NHS worker, and I have suffered racism from the time I came to this country at the age of 9, and it hasn't stopped. And I don't think it has changed much. And, you know, I feel for our people, because to me, not much has changed. And we still have to live through this. We're doing all the things that you're saying. Well, I'm doing all the things that you're suggesting that we do. I exercise. I've got a good social life. You know, I've got my children. I support them. But we haven't got rid of racism, have we? And that's a mighty sort of cause of our stress and distress.
Definitely. I'm sure Dr. Ngwa's got comments as well, but I think you're ultimately very, very right. You're hitting the nail right in the head. And I think the difficulty is that we live it, we experience it every day, as Dr. Ngwa said, and as someone else highlighted again in the chat, is that it biologically affects us. It psychologically, biologically, physiologically affects us. And so there are many opportunities that we are on the back foot, as it were. Do you know, this is a complex question, and I'm sure I'm looking at Lorenti because she's due to close the session. But I think that we've got to do what we're doing at the moment, is in that there's only a certain amount that we can do, and there's a big amount that society needs to do. But we need to keep calling on society to be accountable. And so we need to keep telling them what we are experiencing and about what we are experiencing is unacceptable, and then pushing them to bring change, because there's a lot of things that we don't have power about. But what inspires me is that when things like Elsie was talking about being involved in some of those groups and organizations, because let me tell you, as a medic, I will talk about the experiences of Black people, and some colleagues have no comprehension of what we are going through, have no comprehension of how hard it can be to navigate a consultation. So, but that can only change if we keep telling them what we're going through. And so I think that we keep on doing events, we keep on doing interventions like this, we keep on advocating within our community, but also we keep knocking on the door of all structures to talk about what we're experiencing and to say it's unacceptable. And we do it together because it's tiring. So one person cannot do it alone. We have to do it as a community, but we have to keep on doing it. And you know, that's not that's not a great filling answer, and I'm, you know, rushing it, but I thank you for bringing it up again, because that's the colored elephant in the room.
Yeah. On one of those groups that Elsie mentioned, we're on it.
Perfect. Yeah. No, and I'm inspired today, because we need more and more of this, that we need conversations like this, and we need to be in the spaces and demand our voices. Yeah, no, definitely. Dr. Ngwa, I don't know if you want to comment.
Yes, like you said, it's something we face, and am I optimistic going to change? I'm not. And as I'll quote two people, unfortunately I can't remember the name on top of my head. One of them said, the reason why this thing wasn't changed because we make it seem like it's a black problem. No, it's not, it's a white problem. Right. The moment we start facing it that way, then we'll get some leeway. And there's this dame, I can't remember, I'm sure I'm gonna kick myself. She was very instrumental at the NHS. She retired, she's made a dame, and she said something which I was
Elizabeth, is that Elizabeth?
Yeah.
Oh, I know
she
her.
said, you need to use those experiences and let them change you for the better. And that's what I call the stealing effect, where when they give you lemon, you make lemonade out of it. Unfortunately, it's going to keep coming. Unfortunately, and as sad as it sounds, that's the realization. Because sometimes we need to be able to agree that it actually comes from weak people. That's we need to be able to agree that is actually coming from weak people. And that's where they want to think that they can get your strength. Yeah. So yeah, that's my take on that.
No, I think, yeah, all powerful statements, and it's we've opened a really important area that I'm sure we could talk about for so many hours. And I think you know, people are putting there things like, you know, even a little change is change, and we need to keep trying. And as Bev has written, you know, we can rise, but I think it's rising together and acknowledging that. So thank you. Amber is in Llewellyn. I'm very aware that we are at 12:20 and we are due to finish at 12:15, and so I don't want to chair so badly, but it was such an important topic. But I wonder I wonder whether we have to just move on to Laurenti bringing the session to a close and just apologizing. And if there's anything you want to put in the chat, and we can raise it next week, just in the public discussion. But so apologies, time has run away. But I just want to thank Dr. Ngwa for a fantastic session, which is a testament, because people still want to keep on going on their Saturday morning. And I think that's a real testament to you. So thank you to you and to all you do. And I think that so many things are being learned. But one of the things that was really lovely, I thought someone wrote a comment. Thank you, Dr. Ngwa. You've definitely awoken me to how I can help my 85-year-old father. And I think that's the importance of these sessions. It's reminding us what we can do for ourselves and for our communities as well. So thank you so much. I want to thank everyone that has come on today again for your engagement. We wouldn't be here without you. And I want to thank CATHIP for leading this charge. It's impressive and much needed. And I'm going to hand over to Laurenti now. Thank you so much, everyone.
No, that's great. Thank you very much. Thank you. Thank you, Dr. Ngwa, for a fabulous session, very informative, you know, with topics not to be taken lightly, and great discussions. And thank you to our host, Dr. Vanessa. You've been fantastic. And thank you to all of our attendees today, also on Zoom, on Facebook and on YouTube. You know, and if you want to access today's Health Hour session, it is on the YouTube channel, so along with other previous sessions. And please do complete the evaluation link, you know, which is in the chat box. It would be great to have your feedback and your ideas. And I'd now like to just quickly share our upcoming events with you. If you can just put these slides up, please, Angela. That would be great.
Laurenti, I'll be sharing that for you. Just
okay. Thank you, Ngozi. Right. Just going to share the slides.
I'm attending a conference, but it seems finished, and I'll come and join you.
Okay, fantastic. So our CATHIP Health Hour session next Saturday, is on the topic of menopause, and it's on Saturday, 30th of July, 11 a.m. till 12:15 p.m. and it's Dr. Patrice Arthur who will be our guest speaker. So do register on events at CAHN.org.uk. Thank you. Also, our health hour session on Tuesday, 26th of July, is on heritable bowel syndrome and bowel cancer, because we now have a session on a Tuesday as well, and it's Dr. Abayi Ekta Goma who will be leading on that session, and it's 7:30 till 8:30 p.m. And also following on from today's session, as Dr. Vanessa mentioned, our Healthy Heart session is back again, and it's on African Caribbean cooking and also implications on health. And our guest speaker is Sylvia Ofovi, who is a registered dietitian, and the topic on Tuesday will be African and Caribbean cooking practices, implications on health, and that's on at 6 p.m. till 7:30 p.m. and to register you can email events@CAHN. Also, we'll be celebrating Black History Month on the 28th of September, and the event will take place at Manchester Cathedral, and there will be food stalls, dancers, singers, people who will be reading poems as well, and it's all centred around Black History Month, so please do join us. You can register as well at CAHN events. Also, we'll be having our gala, our CAHN gala, which is our 5th anniversary, and the delivery of annual awards and Black History Month fundraising. And that will be on Saturday, the 22nd of October at Hilton, Manchester in Deansgate at 5 p.m. A fabulous event, so do join us. And if you do need any support from CAHN, we do have a domestic and sexual violence helpline with counselling and practical support. Also have counselling services, with cultural and religiously appropriate specialist service. And it's delivered by Black professional counsellors, so do get in touch if you need a support. And we have family and advocacy support services. So you can email help@CAHN.org.uk or call or text on 077 100 22 382 if you need any support from CAHN. Also, I would just like to say a special thank you to our CATHIP partners, which is CAHN, Black Health Initiative as well, Croydon BME Forum, Enfield Caribbean Association, and the Royal Assembly Redeemed Church, Christian Church of God. Also Rafa International Development Agency. So do contact any of those services nearby you, if you need any support or any queries from them. Thank you. I would just like to say thanks again for attending today, and also do enjoy the rest of your day. Do take care. Join us next week. We'll look forward to seeing you then. And thanks again, Dr. Ngwa, and also Dr. Vanessa. Take care, everyone, and thanks again. Bye for now.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.